Okay, good evening, everybody, once again, and welcome back to another episode of Mondays with Moshe. This is Moshe Norman from Lakewood, New Jersey, and I have tonight the honor of speaking with and interviewing the legendary Ana Gomez. Ana is going to be talking about and discussing the topic of children and complex PTSD, that's post-traumatic stress disorder, and dissociation in children. I know we've covered some of these topics before in adults. We may have touched on them with children. And what's interesting is that some of our previous guests who had discussed dissociation in adults and complex PTSD in adults all said unanimously, well, I can't really talk to children. There's something different about working with children. And just a couple of minutes ago, while I was discussing this with Anna on the pre-show, she kind of said the same thing. She said, you can't really compare the work that entails dissociation or PTSD with children as that we do with adults. Now, the obvious difference is that with adults, you're talking to them, it's talk therapy, they're motivated, they're doing the work, and so they're kind of talking about the trauma, at least to the best they can and to the best of their memory. With children, we're obviously not going to get that same information. So let's jump into the topic. First, Anna, tell us, first of all, thank you for agreeing to join us. I know you didn't know how acclaimed this show is, but now hopefully you do, and some of the famous guests we've had on. But thank you very much for giving to your time just to help the mental health community and improve the learning and clinical competence that we're all craving for and yearning for. So thank you for coming on and joining us.
Well, thank you so much for inviting me. It's a great honor to be here and to be able to share with people what I have learned throughout my journey as a helper, as a clinician supporting children. And I didn't start really working with children, which is interesting. It's not something that I necessarily chose, but came to me, I remember I was working for an agency and I had 5 children that were referred to me because they didn't have anyone else to refer to at the agency I was working. And I was successful. So my supervisor said, Anna, I think you should be working with kids. And they started to refer more and more and more children. And I discovered that passion, the passion that I had for working with children. And that has become a life journey after 27 years, of doing
That's
this.
wonderful. I think so many of us clinicians fall into a niche or some kind of population that we were never expecting to work. I know when I went into this field, initially, I was really hoping to work with couples. That was my passion and creating peace among couples or something like that. And for the first decade, I pretty much worked, I would say like 60 or 70% with children and families, and the rest was with adults and couples. And only now, when I'm a dozen years into my career, am I really moving towards adults and couples. So the experience that you have with various populations just helps you get perspective and just a broader range of understanding of how systems work and how individuals of different types work. So, but tell us a little bit about your professional background and some of your accomplishments, because I know that they're vast.
But so I grew up in Colombia, South America, and came here to the United States 27 years ago. And so I had done a lot of the work, 6 years of work in psychology in my native country, came here, and of course that was cut in half. So I went back to school to get my master's and a master's in clinical and counseling psychology. And later on, I was trained in multiple modalities, especially EMDR therapy. So this is kind of my home, even though I'm trained in many other modalities, from somatic therapies to play therapy to TheraPlay to many others. I had the privilege to be trained as a trainer by Dr. Francine Shapiro, who was the developer of and creator of EMDR therapy. So I was very privileged to be able to work with her and to collaborate in several projects. And so was so excited about EMDR when I learned it. and started to use it with a lot of my children, a lot of the children I was working with. The majority of them, and I've dedicated the majority of my life to working with complex trauma, with attachment wounds, with dissociation. And throughout really the lifespan, even though my heart is with children and the majority of my clients are children, but throughout my life as a therapist, I have also worked with adults and also a lot with teenagers and adolescents. And so I have written, books for psychotherapists, but also several books for children explaining EMDR therapy, books that explain to children how to connect with feelings, how feelings are messengers and they bring a message. And so that's my passion. I'm writing right now a few books. So I'm finishing up the EMDR combined with sand tray therapy that can be used with children, with adolescents, and with adults as well. It's very, very powerful. The union of sand tray interventions within, an EMDR therapy framework. Very, very, very powerful. And so working on several projects, several books and book chapters. I have written several book chapters and I'm writing some. I just finished one on intergenerational trauma, which is also a passion that I have.
Interesting. We had a show on that a number of weeks ago. Yeah, with someone from Australia, George Hallis.
Mm-hmm. Well, and the thing is, over the years, as I was working with children, really what I started to notice is the majority of them present symptoms that are really connected to generational wounds. And wounds that have not been healed in the past generation and now are passed on to the child. And the work that is needed for that, because if we only work with the child individually and do not include any kind of systemic work, then we're really missing the boat here. We're not seeing the larger picture. So that's
is that because there's just going to be a recurrence and a perpetuation of the trauma at home?
Exactly. So you can be doing an incredible therapy with the child and we can see some changes, but specifically with so many hundreds of kids that I work with, if not thousands, these children were improving, but they were going back to an environment where there was not relational safety, not emotional safety, where the child was exposed to wounding relational dynamics. And we were trying to change meta perceptions like I am bad or I'm defective. And these children did very well in our sessions, but then they went back to dynamics that continue to enforce the idea that they were defective or they were unlovable, or they continue to enforce the shame and the pain and the fear. So I have a lot to say about that.
Well, no, that's actually really interesting, because that's another distinction in working with children versus working with adults. If you're working with adults and you're looking at some of their schemas or their perceptions, your self-perceptions, that's something that can evolve between the either relationally between the therapist and the client, or psychoanalytically, or even cognitively. But when you're working with a child and they keep getting thrown back into the lion's den each night, so there's now this kind of two energies, pulling them on different. There's a part of them that's hearing and sensing the safety and belief in themselves from the therapist, but then it's getting destroyed back at home.
Yeah, absolutely. And I also want to highlight that I know parents are doing the very best they can. I mean, being a parent is very challenging as well. And it's even more challenging when you yourself have a lot of unresolved, unhealed trauma.
Right.
And parenting then, has the potential to activate memory networks that hold this traumatic material. And, sometimes we may see or label it as pathological, or label it as a disorder, or label it, as a problem, when in reality is the best attempt of a child to survive, to make it, to elicit care. For instance, a child that is too clingy, or a child that is labeled as being oppositional, or a child that is labeled as being, not following directions. Some of these children really are doing the very best they can with what they have. And sometimes what we see as problematic, or the parents see as problematic, may be the strategy that they're utilizing to activate a caregiving system that is abdicated, that is shut down, or a caregiving system that is in a state of mobilization. You see sometimes parents are in a state of constant mobilization, fight, flight response. So there's a lot of bickering, fighting, right? That's the sympathetic system in constant state of activation. And so the child's trying to cope with that environment, trying to pacify a caregiving system that is in constant state of mobilization, or trying to activate and elicit care from a caregiver or a caregiving system that is abdicated, that is shut down, and that is immobilized, right? And so just it's a very different way of seeing this that really depathologizes and de-shames, the child that is trying to do the very best.
So I want to talk about the child in a couple of minutes, but before that, I just want to ask you, when you talk about dealing with the system or dealing with the parents, so what kind of, there's two things that really have to happen. There's the psychoeducational piece, in which parents need to learn what triggers the child, what kind of behaviors they can do. One of the classical things that comes up is parents who display too much anxiety in front of their children, too much ambivalence and anxiety. And then the child becomes anxious and feels insecure, right? Mm-hmm. And we need parents to sort of demonstrate some level of confidence, some level of strength in order for the child to feel secure, whether it comes to their own disciplining of the child, where the parent has to show a certain security, or when it comes to parents with financial or medical or other stressors that we don't want them to put too much anxiety on the child. So there's obviously that psychoeducational piece that you can do with parents, but what happens if the parents are beyond the help of straight psychoeducation and they need something more? Is that something that you focus on in the treatment of the child? Do you see that as part of the treatment of the child?
Oh, absolutely. And by the way, I think psychoeducation is an important part, but psychoeducation alone, in my experience, will not really do it. And for multiple reasons. One is that what we're trying to do here is really to change procedural memory, that it's not just cognitive. So if they just learn this parenting skills at a cognitive level, when they're in a state of activation, physiological activation, when they're in a state of, stress, or they're in a state of anxiety or fear,
everything flies out the window.
Yeah, they're not able to access that, right? And the idea really here is to restore co-regulation, to restore the role of the parent as that bigger, older, wiser, external, and I'm going to use the words of Alan Shore, the external psychobiological regulator of the child. And I will go even beyond that to be able to be a co-organizer of experience. And with that, so the thing that we have to remember here is children, especially small children, don't have the capacity for self-regulation, different from adults. They don't have the brain regions in charge of regulatory processes are not yet mature. And so all the children need first to experience co-regulation. And then after that, they're able to participate in their own modulation, right? In the modulation of their own arousal. And so co-regulation comes first and then self-regulation. But what happens when you don't have that external regulator? You don't have the caregiver that can be there to regulate the child. Child does not develop the capacity to self-regulate. And so definitely parenting goes beyond psychoeducation. You have to make it experiential for the parent.
Mm-hmm. So, you said that so eloquently. That was beautiful. I wonder how do you make it? In other words, are you then inducing a co-regulation by having the child and parent in the room together and inducing some kind of process?
Yeah, so you do it in multiple ways. And of course, I embed that. It's embedded within the 8 phases of EMDR treatment or any other treatment that we're offering. And so there are multiple ways. So here it is. One is also by being the external regulator of the parent.
Of the parent.
See, by mirroring the parent, by supporting the parent and helping them experience what it is to have another person that can be there for them. You know, I'm right here with you. I know this is hard for your child. Let's sit with it for a minute. Let's notice what's emerging for you as your child is saying, no, I'm not going to clean up the room, right? And so what happens for you, helping them increase mentalizing capacities, able to hold the child's mind in mind. Let's just sit with this and notice as you think about your child, what do you think your child is feeling? Or what do you think your child needs? Helping them be the best tool, teaching them about modulating their voice, even that. I mean, Porges has been talking about intonation. You know, how we have so many things that biology gave us to modulate. We're constantly co-regulating with each other, right? And so then we also have dyadic sessions, and we have sessions with the parent being present, and we play together. And through play, right? For instance, let me give you a quick example. So for instance, if we're playing and there is a puppet that is sad, then we can sit with that sadness. I can say, you know, I almost feel the sadness of the puppet, or I feel the anger of the puppet. I'm going to start breathing with my feeling. I wonder if I can invite you, Mom and Johnny, you know, to do this as we dance with our feelings. See how it's not just the sitting and giving them a whole bunch of, you know, a lecture, but it's about really being in that moment.
Creating the experience.
Yes, I love that. Creating the experience. That's how we can impact procedural memory and not just, you know, explicit cognitive memory.
Beautiful. So, okay, did you say there are different phases?
In EMDR therapy, yeah, in EMDR therapy, yes, but even outside EMDR therapy, this is work that can be done, right? As we also work on expanding the parents' capacity to tolerate affect, because quite often they cannot tolerate their children's emotions. The child is angry, and then they also get activated, or go and buy something, go and watch TV, right? So I don't have to deal with this feeling. So child, you know, they're missing that opportunity to co-regulate. And so we do it dyadically. We show them how to do it. We dance together with those emotions, and then we invite them to do it, to go back home and continue to do the same. If we're doing EMDR therapy, I have to say, for the parent that holds a lot of unhealed trauma, I would say processing their traumatic events will be ideal. Cleaning up the house, you know.
Meaning for the parent to do it with their own therapist?
For the parent to get an individual therapist and do that as well. And that can bring incredible benefits, because that's going to really impact how they relate to the child, how they also create meaning about what the child is doing, because there is a lot of meaning making that guides parenting behavior. And so in that meaning making, the meaning making is influenced by what we have healed and what we haven't. See, for instance, I'll give you an example. A mother, I remember many years ago, a mother always saying, my child is manipulative, my child's trying to overpower me. But in her life, she had a lot of experiences of being overpowered by her own mother that had abandoned her. And so everything was seen through the lenses of her own trauma. And Shapiro says we see the present through the lenses of the past. And if that past has not been healed, then I see my child through the lenses of schemas, cognitive, emotional, and somatic schemas that are colored and tinted by the traumatic events that have not been healed.
Yes. Absolutely. And we recreate or reenact relationships in that way too.
Oh,
We assume that the other person is making fun of us or criticizing or overbearing when they're really not.
yes,
Yeah.
absolutely, absolutely, yeah.
I want to just remind everybody, for those of you who want to ask any questions, please use the tab on the bottom, the reactions tab, and hit the raise your hand. And as soon as you do, we'll see it and I will call on you as soon as I can. Before we continue with the child in the room, let's take a question from Shiffy. Thanks, Shiffy, for joining again, and go.
Hi. So your last comment made me think about the parent who says, there's nothing wrong with me. I just have a really difficult child. Like, this child is just difficult. And I don't want my, yeah, like, I can go to therapy, I can be the perfect parent, but that's not the real world out there. The real world isn't perfect. My child needs to learn how to deal. Sure, I get angry sometimes, but he's going to meet lots of people that get angry sometimes. What do you do with the parent that just says, this is not my problem, this is my child, and my
Yeah.
child needs to learn?
Well, and Shifi, I'm glad that you're bringing that up. And I think that's something that most of us have dealt with, right? And before I talk about what we do, I have to say, when we have experienced trauma, I mean, all of us on this planet, we have to use strategies to defend ourselves and to protect ourselves, especially in the presence of complex trauma. We have to master the art of self-protection. And so it is a giving, and we should expect it, that the parents also with significant trauma, they're going to have strategies. One of the strategies is avoidance, dismissing everything as, no, I don't have any problems, I'm fine, which is not easy to work with strategies and defenses. I mean, I want you to think for a minute about the adult attachment interview. In the adult attachment interview, what we see is categories of attachment in adults, one of which is dismissing, the other one is preoccupied, the other one is unresolved. But what we see from the adult attachment interview, which is how the adults form a narrative of their early attachment experiences, right? And based on how they form this narrative, then a category is emerging, right? Well, we have strategies. For example, the mind that tends towards dismissing states of mind is a mind that will rely on disengagement, detachment, dismissing, right? Everything as, no, that's not a big deal. No, I never had any trauma. No, everything is fine. Okay. And so it is a given that our clients are going to have strategies, a self-protective system. So when I see a parent saying that, the first thing for me is to open my heart with compassion and to understand that this is a parent that has learned probably to protect the self by not assuming responsibility, because that usually will activate shame. Like, I'm a bad parent, I'm not good enough. And avoidance has been something that has been helpful for this caregiver, right? So we have to honor the strategy, and we have to work around the strategy and the defense. And we cannot strip individuals out of their defenses all at once. We have to gently, like the onion, peel one little layer at a time. So if a parent says that, absolutely, I'm so glad you're telling me this, that this is how you feel. This is probably a parent that I wouldn't say, well, therapy may be needed, because then the defense will go really, really strongly against everything that I propose, right? We meet them where they are. We join them with an open heart, an open mind, with synchrony, right? And continue to work with them as much as we're able to. One analogy, because I use a lot of analogies, I think it's important to speak the language of the right brain. It's important to have the whispers of the right brain in the psychotherapeutic process. And so one of the analogies that I do with parents is I say this, mom and dad, some parents come in and they want to clean up a house. They clean up the whole house. Some want to clean up a room and some want to clean up just a table. And that's okay, whatever we're ready and want to do. Okay. So if we clean up just a table, then I'm going to be mostly working with your child. That's it. With your child, I'm going to be doing most of the work with just your 7-year-old, your 8-year-old, your 10-year-old. If we clean up a room, then I'm going to be meeting more often with you because mom and dad, you are fundamental in the life of your child. So we have to really highlight the importance of the parents in the life of this child. And then, if we clean up the whole house, then of course, we're going to have a lot more work with you. We may even get an extra helper that can support you, that can help you through this journey. And so we have to de-shame, lots of de-shaming. See, if we just say, I think you need therapy, we're going to be in trouble right there. And most likely they will not come back because the defenses will come to protect them, right? And it's not something that there is a formula. It's the art of psychotherapy. See, it's not a formula, but it's that frequent dance of acceptance and join them where they are and move them just one little bit deeper, right? As they develop a greater connection with their own selves. I hope that makes sense.
Thank you so much. That was
Beautiful.
beautiful. Thank you.
Really beautiful. Okay, so thank you, Shifi, and thank you, Anna. Let's talk a little bit about the child in this session.
Mm-hmm.
We don't necessarily know when a child comes in with any kind of trauma, let alone complex trauma, and we only are told about symptoms. Sometimes we're told about trauma. What do we see in the child's expression that starts to give us some hints as to what's really going on?
Mm-hmm. Yeah, so there's a lot to say here. It's a very rich topic because, first of all, children don't tell their stories in a well-formed, coherent, cohesive narrative. Instead, they tell the stories through reenactments in the play. If you do sand tray, for instance, they create stories in the sand tray. They create stories with puppet shows or just non-directed play, right? We also hear during the Klein history in psychosocial history, we hear, the story. Sometimes the trauma is known. Sometimes the trauma may not be known. Maybe the child has never reported it, but we also look at the symptoms. We have to remember that the child and the parents are telling the story. We just have to keep our eyes, our ears, our hearts, our bodies open to feel what is emergent moment to moment throughout the therapeutic process, because the story is telling itself. For instance, I had a child that was abused at a shelter. And this is a child that couldn't escape, and she wanted to be rescued. You know what she did every time she came to my office? She wanted me and mom to find her. So we always played the game of finding her. And she loved to hide in, every single little corner I had in my office, she will hide. And she wanted mom and I to find her. And we celebrated, and then she will hide again. So mom initially thought that was a waste of time, but you have to sit down with parents and explain that children use a very different language. And so she's telling us a story. So kids tell stories through their native language, which is play. You also listen to the symptoms, okay? You have a child that is having nightmares, a child that is having a hard time sleeping. You have a child that is not functioning well at school, a child that exhibit symptoms of anxiety or depression or aggressiveness because or dysregulated anger outbursts, tantrums. Children don't show depression in the same ways that adults do. See, a child may be just tantruming a lot. A child may be having difficulties with, like enuresis or encopresis. So we really have to look at the symptoms that these children are exhibiting, because the body is also telling a story, right? The symptoms are telling a story. Look also for somatic reactions. So I always tell children that we have 3 storytellers: the mind, the heart, and the body. And they tell stories. The mind through images and thoughts. The heart tells stories through the feelings that we have. So this is also a way of depathologizing. See, if I have anxiety, doesn't mean there's something wrong with me. It means that my heart is holding a story that needs to be heard. I tell kids that feelings need air, need light, and need wings. And so we let the feelings come out, and the body is a great storyteller, because the body can tell us a lot of stuff. We may be feeling tingling in the tummy, and that tingling may be part of a story. Maybe that I'm scared. Maybe that something happened to me, right? So listen to the storytellers. Listen to the body. Sometimes they have somatic reactions, stomach aches that the doctors cannot find a reason for the stomach aches to be present in the life of the child. Headaches, irritable bowel syndrome. I can't tell you how many children I've seen lately with a lot of somatic complaints that I didn't see years ago. The stress, the COVID is really stressing the system of our children. And so we have to look at the full clinical landscape, to look at symptoms, to look at what the body is telling us, to look at the history, to look at the reenactments, to look at what they create through play, non-directive, sand tray, puppet shows. And what you see is the story begins to unfold.
So really what you see is what it is. The same thing would apply, I'm assuming, to reenactments between the child and the therapist.
Absolutely.
Right? That whatever, if you sense some kind of resistance or opposition, or whatever it might not be, what about selective mutism?
Oh, absolutely. Yes. Oh, yeah.
So what happens? I mean, I'm sure, just like you're describing, that children's language is different, then the treatment must be different also. I'm assuming that even once you figure out that there's something underlying this behavior, you won't necessarily get a coherent story, verbal story from a child. And certainly if the trauma was pre-verbal and the child can't even access it if they wanted to, you're not going to get a full story. So in that case, what are we doing? Is there a difference between various traumas in how we might react and treat? Or is it all about just allowing, permitting, accepting, and attaching?
Well, so I think that a lot of traumas shared. Some of the work that we do, we do it regardless of the specific trauma. But there are also very unique elements when it comes to treatment. If we're dealing with children, let's say with sexual abuse or physical abuse or neglect or medical trauma, right? Or injuries of attachment. But for the most part, most treatment, and this is coming from Pierre Janet in the 1900s, usually what we consider best clinical practice is when we have a period of stabilization, processing of trauma, and integration. Okay, so the stabilization, for instance, in EMDR therapy, we call it preparation phase. Okay, but it's all about stabilization. So the stabilization, it is going to look a bit different. And honestly, I feel like we should be doing some of the things we do with children with adults. I mean, I truly believe that the play system is fundamental. I mean, Young Panza spoke about the play system as a biological system, but during the stabilization phase, we're going to work on bringing that ventral vagal system that Porges speaks about, bringing it alive, stimulating ventral vagal system, restoring resonance between the child and the caregiver. We're going to work on, we're going to use polyvagal based strategies that work directly with the lower brain. So we have to see where the child is. Some children are able and ready to use cognitive strategies for emotion regulation. But some children, especially the ones with complex trauma, with dissociation, with developmental trauma, see, these are children that we're going to need to start working with the lower brain. And this is, even coming from Bruce Perry. So we're going to use sensory modulating strategies, even occupational therapy focus on emotion regulation. So we're going to work with sensation. We're going to work with sense. We're going to use movement. We're going to work on really bringing that ventral vagal system back online. We're going to work individually, and we're going to work dyadically with caregivers. And when the child has enough capacities, because it's not about throwing them into the traumatic event, we want to make sure that when they exit the traumatic event, number one, they have enough capacities to be able to navigate through the cognitive, emotional, and somatic schemas that are held within memory networks that have this traumatogenic material, okay? And we're going to continue to use play as we process memories of trauma. There are now a lot of advanced strategies that allow us to go in and break the memory into smaller kernels, smaller pieces. Or we use what we call pendulation strategies, where we go just a little bit into the trauma and come back into a resource in a regulated state. So it's going to depend on the child. I believe that the treatment of trauma is not a one size fits all. And if we do it in that way, we're negating diversity. We're negating individual differences and the uniqueness of each of our children. So we want to honor the uniqueness of the child and see where the child is. We create a baseline, what kind of capacities the child has been able to develop, as well as the environment and the caregivers. And then we're going to enter the embodied mind of the child through portals that allows the child to process the memory without becoming overwhelmed or flooded emotionally. And we can even, I'll give you an example, we can even process a memory by using distance. So it may be a story that the child created about a kitty that was being hurt. Not me, the kitty. Not my sadness, the kitty. Not my fear, the kitty's fear. And so we use the stories that the child creates to process them, here specifically with EMDR therapy, but you can use other forms and other modalities.
So that's a great strategy. That's a great idea of a strategy for accessing information from a child and using it to process, sort of almost directly process the trauma. Again, what would you say when the trauma is either pre-verbal or not accessible, or they won't express it? How are we working sort of parallel with the trauma without actually either knowing what it is, or the therapist knowing what it is, or directly talking about it?
Well, so when we're working with pre-verbal trauma, trauma that remains in the implicit mind, that remains underneath awareness, is underneath the awareness of the higher cognitive mind, but the body tells the story, see? And so I'll give you an example. I have worked with so many children coming from orphanages, and one of them, I remember, verbally, she will tell you everything is fine. My experience at the orphanage was fine. But she will create very horrific stories of babies being hurt. A whole bunch of babies, a lot of babies being hurt. One of the things that happens, especially when there is early chronic trauma, which is what we consider complex developmental trauma, is that again, the mind is not able yet to acknowledge, cognitively and consciously what happened. However, through play, the mind finds refuge in the play, in the sand tray, in the puppet shows. And so in the sand tray, she will create a lot of stories of babies that were hurting. In the literature of complex trauma, one of the things that we hear is that the mind that has experienced complex trauma finds refuge in the not me, not mine. Meaning, that didn't happen to me. That's not me. That's not my anger. That's not my sadness. That's the refuge, right? So we join them there. It's not me, it's the kitty. It's not me, is the little zebra that is being attacked by a tiger. So, and I'm not saying the child is lying. It's just that procedurally, this is how the body, this is how the mind can tell the story without yet acknowledging it.
So I want to ask you a question about that. I know on our caseload, we have a child who I don't know the exact history because I'm not working directly with this case, but there seems to be a lot of dysfunction in the family. Probably, I'm going to guess there was a lot of neglect. That's my, at least emotional neglect. And the child lives almost I think he's 9 or 10 years old, and he lives almost in a completely alternate reality.
Mhm.
He makes up stories and lies, and it seems from the descriptions that I'm getting, seems more and more that he's not actually lying. He's just living in an alternate reality.
Mhm, mhm. Well,
So
and that's the refuge of the mind,
yes,
right?
so that's is this the refuge, and is this considered dissociating from reality or splitting from reality, or is this something different than dissociation?
Well, so there is a type of dissociation that has to do with living in the fantasy world. So it could be a dissociative state, but it may not, because to diagnose dissociation, you really have to look at multiple variables and assess multiple areas. Is it fragmentation? I don't know. And it doesn't necessarily mean that there is fragmentation of the self. But certainly the child has found refuge in the fantasy world, but that tells the story.
Right.
If you cannot have a life here and you create an alter reality, that speaks about the life experiences that you had. And the other thing that, this can take hours to address is the redefinition of trauma. We tend to think that trauma is only, physical abuse, sexual abuse, an accident, witnessing a homicide. But how about attachment injuries?
Sure.
Those are,
I think that's most of what we see
yeah.
in our practice, even with adults, certainly with adults. The
Oh,
people
yeah.
that come, yeah. So okay, so let's go with that for a minute. In the treatment of this young boy who is living in an alternate reality because he cannot cope in his current reality, or he couldn't cope in his past reality if it was one of neglect, would we join in his alternate reality and just live there with him? Would that be the place to heal, because we're essentially reattaching or creating new attachments with him? So let's put aside the content that the child's living in an alternate reality, which is causing him potentially to be bullied at school because he's making up all these stories, and the kids are saying, it can't be that your father's a policeman and a fireman and a whatever, and he's getting he's getting hurt socially. Do we join the child in there and sort of encourage the narrative in the story, or do we do something else?
Well, I just think it may be larger than that. And I'm hesitant to give any kind of or provide any kind of suggestions because I don't know the child.
Mhm.
And so everything is contextual. And so I don't know the context in which this is emerging, how it's happening. So I would be hesitant to say anything about this specific child.
Okay.
However, I can say that there must be a reason why the child lives in an altered reality. And what is happening in the real life that is not sufficient for a child to have to find refuge in another altered reality. So as a psychotherapist, I'm going to be looking at the family system. I'm going to be looking at the relational environment, even before the child was born, because epigenetically a lot happens while the child is in the womb. So we're going to look into even, before the child was conceived, how was the climate of the family? What was happening around? I want to understand the history of the parents, the mom, the dad, or any other caregiver that, any other adult that participates in the care of this child, right? Relationship with siblings. So I really want to understand the full clinical landscape to understand really what is the function, because we have to look at the function. What is the function of the symptom? And what is the function of this fantasy? Okay. We also utilize instruments to assess for dissociation. There are several instruments like the child dissociation checklist from Putnam. And this is one that we give to the parents. I'm going to be using the CDES from Stuhlback with the child just to see, and depending on the age, if I see greater red flags as I use this instruments, then I'm going to do further assessment, a clinical interview where I specifically ask questions about potential dissociation. And so how much is present? We look at it as a continuum. Do we see mild dissociative tendencies and then fantasy, prone to fantasy and absorption? Do we see moderate dissociation where the presence of depersonalization and derealization is there? Are we seeing fragmentation? Are we seeing more severe dissociation, like DID, dissociative identity disorder, or OSDD, other specified dissociative disorder? And this isn't to pathologize. I'm not into labels. I have to admit. I believe that for too long we have pathologized the symptoms of trauma, and we have further pathologized the victims, and we have further pathologized and shame individuals that have experienced trauma. And so, but
I think that disclaimer, is that like in the Bible of people who study complex trauma? Is that part of the Bible? Like you have to disclaim that we've been pathologizing and labeling too much for too long?
I
think most of us understand that it's for context. It's really just it's for insurance and for context. So we kind of have an idea and a grip of what's really going on with this person. How do you, what are some of the basic signs to start being concerned or suspecting dissociation when you're meeting with a child?
So with dissociation, the following are some of the symptoms that we see. Let's start with mild. So with mild dissociation, what we see is a child that is kind of spacey. Unfortunately, a lot of kids with mild dissociation get diagnosed with
attention deficit.
Absolutely. And they're treated with
psychostimulants.
Well, by the way, psychostimulants are play suppressors, okay? And so for a child that needs play to shape the midbrain, we're actually depriving them from play. Okay, so when it comes to mild dissociation, it's kind of a child that seems kind of fantasy prone, spacey, not very much present. As we move into depersonalization, derealization, some children may report watching themselves outside the body. You may have a child that seems like, like doesn't distinguish between like this is a dream state or reality. derealization, like they're in a dream state. And as we move into more severe forms of dissociation, then we find in children more of the precursors of adult dissociation. So we may or may not see the clear fragmentation. We may not see the dissociative parts, a structure that is dissociative. We may see like trance-like state, for instance. We may see a child that gets so angry that then doesn't remember anything that happened. So we may see memory losses where they don't remember exactly what they did or what happened. It's difficult because sometimes children may lie about what they did, but the dissociative child truly does not remember, right? So that's kind of a quick overview of some of the symptoms that we may see in dissociative children.
Excellent, very clear. Thank you. Well, would psychostimulants make a difference in children who are struggling with something close to dissociation or dissociation? Because I've seen so many kids who are prescribed with psychostimulants or the like, and there's an overwhelming, feedback that there's something that's been helpful. They changed in some way. And in some of the cases, I don't really believe that children have ADHD. So, will stimulants have that effect on children who are dissociating also?
Well, so if it's just dissociation, pure dissociation, I would say that psychotherapy treatment, the restoring co-regulation may be the way to go instead of
I think I'm asking more because, for the sake of diagnostics, are we ruling out dissociation if the stimulant is reported to be helpful? Or are we saying, well, nah, just because the kid took a stimulant and he's feeling, he's somewhat more grounded, he's somewhat more attentive, doesn't rule out dissociation?
Well, so the thing is this, first of all, I don't think that neither the diagnosis or the treatment of dissociation is just one-sided, but instead is multifaceted, and a multimodal approach to it, I think is the best, with the diagnosis, the assessment, and the treatment. And as such, we cannot just say or rule out dissociation just because the child is reacting well or not reacting well. That may be one red flag, okay? But it's multifaceted. I mean, it's really complex, the assessment, the exploration, and the treatment of dissociation. And it's multifaceted because how complex it is. So certainly we will pay attention to that if medication is not working. And so maybe the diagnosis is not ADHD, maybe a dissociative disorder here, or maybe a child that is prone to dissociation. But we have to look at the bigger picture. We have to look at the entire clinical landscape to be able to fully diagnose and understand if there is a dissociative disorder or not.
So how do we find clinicians or diagnosticians who are proficient in things such as, in identifying and diagnosing let's say dissociation or complex trauma? It's so complicated with children because you can't always get accurate information, linear or accurate information. How do we find clinicians who are, does someone have to have some sort of certification in dissociation, and how do we know when to refer? I guess part of what I'm struggling with is you have a child comes in, he seems to be, let's just say, classically presenting with ADHD symptoms or oppositional defiance. How would we know to refer them for further assessment in something like complex PTSD or dissociation? And then who would we refer them to?
Yeah, so that is very challenging. And it's challenging because even now, some people don't believe that there is dissociation. And so we have a field that is not unified.
It's just in the imagination.
Yeah. And so it's not a unified field.
It was a joke.
Probably for everything I'm saying, I bet you there's someone out there that believes exactly the opposite.
Well, for sure, it's all in the diet. It's
Yeah.
about what they're eating.
Yeah. And so with that in mind, not until now, I feel like there is greater openness in our field to really acknowledge the presence of dissociation in children, in adolescents, and in adults. So finding someone that has the label of, I specialize in diagnosing dissociation, very likely we won't find that. What I can say is, for instance, now we do have more people interested in complex trauma in children, in the treatment of complex trauma and dissociation. We have, for example, the International Society for the Study of Trauma and Dissociation, is the ISSTD, a place where I highly encourage you to go. They have trainings, they have conferences, they have free resources for clients and for clinicians. So that, for instance, is a good resource to
So
have.
can you say that again? I want to put it in the chat box.
Sure. Is the ISSTD. So is the International Society for the Study of Trauma and Dissociation. That will be a good resource to find clinicians that have greater expertise in complex trauma, dissociation, trainings also, and resources for clients and clinicians.
So we would have to search that out, and I guess the clinician would have to tease out whether there's something beyond what they might be familiar with.
Yeah, and I think, I think it's about also attending advanced trainings in this area. And there are a lot now, a lot of trainings in how to treat complex trauma, how to work around dissociation. There are a lot of certificate programs now for adults. For children, we don't have yet one, but I know the ISSTD has a program specifically for dissociative children. So this is a place where you can go for training. I have presented several times, and I teach for ISSTD as well. So it's a good place to start, because I think that if we all take accountability and responsibility also, we just need to attend advanced trainings, read, and the other thing is get consultation. I have to say one thing. I don't think any of us, I didn't really choose to work with complex trauma and dissociation, but I had a client that was highly dissociative, and no one around me could take her because no one had the expertise. So my choice was to say, I'm sorry, I can't treat you, or to get myself into trainings, read books. And that's how it started.
That's it.
Then I started to read.
You could withdraw or lean in, and you leaned in.
Yeah.
And it made a career out of you.
Exactly.
Well, good for you. We should all hear that and be inspired. There's so many younger clinicians who I work with or supervise and say, that case is too hard for me. I want to run away from it. And I say, that case is too hard for you. That's why you're going to do it.
Mm-hmm.
Right. And that really shapes our careers, because it's the things that we're most afraid of that we're forced to work hardest on. And then we can get really good at it because we're not as afraid of them anymore. We develop a taste for them.
Yeah. And I'm so grateful for the most challenging cases I had, because right. I am the therapist I am because of them.
That's right.
And because of them, I started to read, study, attend trainings connected to complex trauma and dissociation. So that's how most of us began.
Is there a difference, Anna, in the way you treat children with dissociation and the way you might treat those with complex PTSD? Is there anything differently that you're doing because of the dissociation and trying to bring the client back, or?
Well, so yes and no. There are things that when you work with complex trauma and dissociation, there's a lot of overlap, because the child with dissociation also has complex trauma and very likely developmental trauma. But there are some specific issues that we must work with the child that presents with dissociation that are very unique to the child that is dissociative. And it's also going to depend on the severity of the dissociation that they present with. For instance, a child that already shows an inner dissociative structure of parts, so there's already division in the sense of self, then definitely we're going to be working with the inner system. We're going to have to identify those parts of the self. We're going to have to work with that inner system. We have to take that inner system into account because it's going to be different from a child that shows fragmentation compared to a child that doesn't. So let me give you an example. Let's say you're inviting the child to create a resource, a place that feels good and happy where you can go and feel good. The child with complex trauma, without dissociation and fragmentation, you do the safe place. You don't have to ask if all the parts of the self are okay with this, because there is a sense of self as a unit. The other child with a fragmented sense of self, and this has happened to me, you ask them for a safe place, and what is safe for one part of the self may be very activating and fear-provoking for another part. You may later on, when you're processing memories of trauma, you think that you had a very successful processing session, to find out that another part acted out and there was an episode of self-harm, right? And so, yes, there are differences, big difference, especially when you're working with a system that is already fragmented. Now, when you're working with mild dissociation and you don't see the presence of fragmentation, then it's going to be more similar, to the work that we do with just complex trauma, developmental trauma. But we also have to check how present the child is. In the MDR, we have to be checking how much the child is here or how much the child is drifting away. So there are differences. And the differences are greater as we move on this continuum of dissociation and we move towards greater fragmentation.
Can you distinguish dissociation from fragmentation? What is fragmentation?
Well, so this fragmentation meaning severe dissociation, where you have a system of parts.
Parts where the real now splitting.
There is a split, exactly. Mm-hmm.
I see. Okay. Let's take another question from Shifi. Go ahead, Shifi.
So my first question to you that I was formulating in my head was, what are the dangers of dissociation? But then as I'm listening to you, I'm like, oh, I get it. I understand the dangers. And then I started panicking. I'll give you a little history. I run an internship program at an organization that provides services for families of incarcerated people. And we have a fairly large client base that are children. And often I hear stories. So I'm not the clinical supervisor. I'm a new clinician. I'm not qualified to do that, but I do coordinate a lot of the pairings between the interns and the clients. And what I hear from some of the interns are stories about, oh, my client just in the middle of the session started talking in third person. My child client started talking in third person about herself. Clients that only want to play Roblox, like that's where they live. They play it all day, every free moment. They don't want to talk. They just want to play Roblox with their intern. We do all our work via Zoom. Our work is national, like across the country. And I'm wondering, at what point do we say, okay, this is severe, like you would say, fragmentation, and this needs to be referred out. This is not something that an intern can handle. Short-term intern, they work an average of 8 months. Obviously, they are supervised, but they themselves are not yet seasoned. So at what point do we say, okay, this needs to be referred out?
Yeah. And I agree with you, Shifi, I'm sorry.
Shifi. Yeah.
Shifi. In terms of making sure that these children are treated by someone that is qualified to do it, because these are children that if you don't provide adequate treatment, you can cause greater harm and damage to the system, right? Now, children are resilient, but also these are children, usually if they present with a system that already shows division in the sense of self, these are children that very likely have the marriage of disorganized attachment and severe trauma. Okay. So at what point I refer them out? So you start to see little red flags, right? Talking in third person, trance-like state, spaciness, potential amnesia where they forget things or they don't report, or sometimes in the middle of a conversation, they want you to call them by a different name, or they hear voices and the voices are telling them to harm themselves, for instance. Very high percentage of very dissociative clients show self-harm. I just read an article where there's a very high percentage that could happen. So we see some of the signs. The first thing I would say, if the signs are strong, I would say refer them to a more seasoned clinician right away. If the signs are not strong, you have 1, 2, but everything else seems okay, the first step is to utilize instruments like the CDC. In fact, Onno van der Hart, which is one of the leaders in the structural dissociation world, he says that trauma, that dissociation is the heart of trauma. Dissociation is the heart of trauma. If dissociation is the heart of trauma, that means that if we're working with traumatized individuals, we should be assessing for dissociation. So what I do is that after the intake, right away, I'm giving my parents the CDC, the Child Dissociation Checklist. So I would recommend that most kids should be assessed for dissociation, and starting with basic instruments like the CDES and the CDC, the Child Dissociation Checklist. See what happens. Start asking questions to the parents. Have you heard your child say this before or talk in third person? So expand, ask more questions specific to dissociation. If you get more red flags, then it's time to maybe find a more seasoned therapist or someone that has greater knowledge in the treatment of complex trauma.
Thank you. I found it fascinating that you said sometimes you can be having a good processing with one part, but activating another part. And that's really what got me thinking, wow, this needs someone that's really adept to be able to monitor that and work with that. Thank you.
Well, this is a tremendous amount of information in a very short amount of time. So thank you. And you said it also eloquently. Any last questions or comments for Anna before she goes for the night? I want to thank Aaron Herzog, who's very comfortably sitting back there, for bringing her. I think Aaron has used you for consultation in the past.
Yes.
Yeah. Wow. So chose, Aaron, you have good taste. You chose well. Okay. Any last questions before we call it a night? Well, Anna, I want to thank you again for coming on and sharing all this for us. You've given us not just information, but a tremendous amount of food for thought. And this was absolutely fascinating. And I'm hearing so much integration of different modalities to access different either parts of a child or modalities to get to the child. And I think that that's very rich in and of itself. So that I appreciate that also, sort of everything coming together and you accessing different things, different resources to work with a child or the parents, like you said, theraplay or some kind of other dyadic integrative modality. So I think that speaks to the skill set that, we all have to strive for. So
Mhm.
thanks again
Well,
for,
you have to have a bag of tricks.
Yeah.
So using play, using expressive art,
right,
movement. But certainly the last thing I would like to say is you are your best tool. Your heart, your openness, your voice, the movement, closeness or distance. So you are your very best tool. And you are, as a therapist, also you are an external psychobiological regulator of the child. So you're an external regulator for the child. You also co-create meaning with the child. And because of this, interactions with you where the child feels regulated, there are new synaptic connections developing in their little brain. And so the relational aspect is fundamental because
Yeah.
that creates safety. And I think I was telling you in the beginning, Steve Porges says, safety is the number one need of the brain and the nervous system. And
Yeah.
so it's not safety, just, the absence of something dangerous. Is relational safety, is trust,
I think that's the most fundamental takeaway from this whole discussion is really that, with all the more complicated things that you discussed, on a most simple level, it's really having a therapist be extremely mindful of their own reactions to the child, because those reactions could be very, very triggering, or they could be very co-regulating. And the more, I'm assuming that the more long-term co-regulatory relationship that's built between the client and the therapist can probably start to be less careful about that and start to interact on a more, like Shiffy said, real world, where the therapist might be able to be more reactive and the child not be as triggered because that co-regulation is leading at this, at this time to self-regulation. So it's really important to stay mindful of the reaction.
Yeah, and be connected, mentalizing capacities. That's a concept that is very old and that come from, the adult attachment interview and then Peter Fonagy. But our capacity to hold the child's mind in mind is fundamental, because with that, we can resonate with the child, we can connect, and we can respond contingently to the needs of that child. And ultimately, what we're providing is a corrective experience for the child. See, so now the child gets to experience a human that can get to see him or her, that can get to respond in a way that is contingent.
Right.
So the child feels like my needs are seen, my needs are met. And that's something that for many of these kids, they never had.
Yeah, and frankly, for adults as well. I mean, like you said, all the way in the beginning, you talked about the parent who can't self-regulate. That parent is still a child in their incapacity to regulate. And of course, the child is going to continue to be affected by that. And like you said, by you being a co-regulator, or you used a different word?
Co-regulator and a co-organizer.
Co-organizer. You have the capacity to really provide the parent with regulation skills or self-regulation skills by your regulating the parent. And that,
absolutely. Yeah.
So even if we put the children on the side, for those of us who are working with adults with primitive personalities, or poorly developed personalities and regulation, I mean, this is very similar.
Yeah, with the adult, we're also co-regulators, right? And we co-regulate each other, even here, the voice, the intonation, looking at each other here. So we're constantly co-regulating. And so we do that with our caregivers as well. And we teach them by helping them experience what is to have us there as companions, as witnesses, right? Like I'm right, I always tell the parents, I'm right here with you, Mom. I know this is tough. We're going to get through it. I got you. I have the space right here for you. Because a lot of these parents feel alone. They feel on their own. And so we provide these corrective experiences that also support the healing. So really what I what I advocate for is a more multimodal approach, right? Where there is the relationship that holds the experience, but there is also curiosity. There is intention. That's another word that I always tell my consultees. Don't forget this word, intention. Be intentional as you go through the moment-to-moment decision making in the therapeutic process. And then we use techniques and we use play, but they're surrounded by all of this beautiful, capacities and models that support the healing of our clients.
Amazing. Okay, well, thank you again. That was really informative and a real honor to have you on. And thanks for joining.
It was a great pleasure to be with you, and to all of you. Thank you so much for inviting me.
Okay, be well. Have a good night.
Okay.
For those of you who want to stay on and say hi, I'd be happy to meet you if I haven't met you yet.